Okay, so it's 2 minutes past 12. Thank you all for joining us today. I'm delighted to introduce you to my colleague Nell Warner from CASCADE. Dr. Nell Warner is going to talk to us today about her recent research project, Parental Risk Factors and the Likelihood of Children Entering Care, which is funded by Healthcare Research Wales, Welsh Government. What we'll do is Nell will make her presentation for about 40 minutes, I think. Yeah, Nell. And then during the presentation, if you've got any comments or questions, if you could put them into the chat box, please. And at the end of the session, after Nell's presentation, hopefully my colleague Sophie, who's going to join us, will read out your questions to Nell for the discussion. And also at that time, after the presentation, if you'd like to ask any questions in person rather than over the chat box, then if you raise your hand at that point, my colleague Freya and I will switch on your microphone when Sophie tells us to. So without further ado, thank you, and over to you now.
Okay, right. Thank you very much, Sian. So as Sian has said, my name is Nell Warner and I'm a research associate here at CASCADE. I'm going to be talking to you today, and I'm really pleased to talk to you today about my the research that I've been doing on parental risk factors and the likelihood of children entering care. It's a Healthcare Research Wales funded project, and I've had a lot of support from a lot of colleagues in other places, including Swansea and Lancaster University. So the rationale behind the project is that, as I'm sure you're probably aware from other studies and from work in social care, that there are already we know quite a lot about that some issues are risk factors for children entering care. So we're talking about things like parental drug and alcohol misuse, parental mental health issues, domestic abuse, learning disabilities, and so on. These sorts of things in parents. Now, the study that I have done and that I'm going to be talking to you about now is a study that I did with existing data. So data found from social services and health and education. So in determining what risk factors I was looking at for the study, I was determined by what was available in the data. So the specific things I'm going to be talking about now are drug misuse and alcohol misuse. I've looked at different types of mental health issues, so depression, anxiety, bipolar, schizophrenia, other types of psychotic disorders, eating disorders, and self-harm. I've looked at assault at home, which means people going to A&E having been the victim of a violent attack that's taken place in their house. I've looked at learning disabilities, so that is adults who have an IQ of lower than 70, but I have also looked at learning difficulties. So those are more cognitive problems like dyslexia and dyspraxia. And we looked at those because in planning these studies, we often have the involvement of people who, public and people who've been involved in social services. And we discussed this with some parents who've been involved with social services, and we had some advice from a parent on that group that they had difficulties because of they were dyslexic and had literacy problems, so they felt that social services thought they weren't engaging with some of their issues. So we decided to add these sorts of cognitive learning issues to the research. We also looked at autistic spectrum disorders in parents and ADHD in parents. So we looked at these to find out, how much impact they were having on the likelihood of care, but we also wanted to find out a lot more about the circumstances in which they were having an impact. So we looked at a whole range of different issues. So this included who in the household had the risk, if they had the same impact in women, in biological mothers, or in men in the household. It included what was the difference if there were multiple risks in a household, or somebody in a household with multiple risks. What was the impact of having somebody with no risks? Was there a protective factor? We looked at how these risks are interrelated with poverty. We know that poverty is very related to the likelihood of children going into care, but these risks are also related to poverty themselves. So is poverty having an impact because there's more of these risks in in where there is poverty, or is poverty, is there some other mechanism? And do these risks have the same impact on the likelihood of care if they are occur in households where there is poverty? Then we looked at variations across local authorities. I'm sure you're probably aware that there are quite big variations in the likelihood of children entering care in different local authorities in Wales. So we tried to look at how much these risks might account for that. There's also different levels of risks in those populations. So how much difference was there in the likelihood of care when these risks are taken into account? And do they have the same impact in different local authorities? We also looked at how they interrelated with child characteristics. So this was things like the child's age, the child's gender, the child's ethnicity. Do they have the same impact for all these children? And do they account for any differences that we might see in the likelihood of children going into care in, for example, different ethnicities? And then the final thing that we've looked at is changes since 2008. So the majority of work that I did, I looked at the likelihood of children going into care between 2016 and 2020, but the final thing I did was to repeat that for children from 2008 and looked at it with a couple of different cohorts of children to see if these risks were having the same impact over that time period. So I think I have already mentioned that I did this using existing data. And I used a facility in Swansea University, which is the SAIL Data Bank, to do the work. Many of you may already know about the SAIL Data Bank, but in case you don't, it has been set up by Swansea University as a repository for different types of data sets, and researchers can apply to use these data sets. All the data in those data sets is anonymous, but it's the sort of data that has been collected by Welsh Government. So in terms of social care, we have data from Welsh Government about who's entered care, who's a child in receipt of care and support, and so on. It's data from health, and there's data from education, and there's other data sets. So it's all anonymous. And I used a facility in the SAIL Data Bank to identify households which had children in it. It's based on which children are registered, which individuals rather are registered at the same GP practice. So using this facility, it's completely anonymous, so we don't know where the households are, but we don't know which households they are, but we can link individuals together. So I used this to make a data set of all the households that had children aged between 3 and 17 between 2016 and 2020. And I linked it to data from social services to find out which of those households had had a child, one or more children, enter care during that time period. I linked it to birth data to identify who in that household was the biological mother, if she was present. There isn't a facility in SAIL, unfortunately, for identifying biological fathers, so I knew if the mothers were present, or if men were present, or if other women were present. I also linked it to 4 different types of health data, so data from GPs, inpatient data, data from A&E, and the NHS Substance Misuse Service data to identify those risk factors. So all those risk factors in adults in the household, not in children, in the adults in those households. And I also linked it to education data, and that was to get 3 pieces of information. One, whether the children in the household were eligible for free school meals, also whether they were their ethnicity and their special educational needs. So what I ended up with was a household, a data set of households of 293,000 households, each with a child between 3 and 17 in the time period, and about 2,763 had a child enter care, and the rest of them were comparison households. So I was able to do a lot of really interesting work comparing the households where the children had entered care with those that didn't. within that data set, I had, just to give you an idea of the scale of it, nearly 1.2 million individuals, and just over half of those were adults who were residing with the children. The reason it was 3 to 17-year-olds in particular is on two reasons, really. One, it meant I could link it with the education data and find out information about free school meals and so on, which was really useful for part of the study. The other reason was that at the time I did it, the data from social services had just come into the SAIL data bank, and there was a lot of problems matching the younger children in that data set. So there's been some work done to improve that, so hopefully they can be used for future studies. But for this study, we weren't confident that of the quality for using those children. So this is the first little bit I'm going to show you with some results on. This is a chart which shows you the risk factors, the percentage of households which had the risk factors. The green households are the households where somebody has entered care, and the sort of, it's a kind of plum colour, I don't know if you can see it, those are the households where nobody has entered care. So you can see that on the whole, the green, the charts with the green bars are much bigger than or they're bigger anyway than the chart than the purple bars. So that shows you that there are more children, that these risk factors are more prevalent in the households from which somebody has entered care. There's a few things that are quite interesting to note about this. You can see from the depression figure is I was quite surprised when I saw this. It's remarkably high. So even in the households where no child has entered care, 23.6% of them have an adult in that household who is depressed, and this was counted in the 2 years before a child either did or did not enter care. So for drug misuse, alcohol misuse, assault at home, other psychotic disorders, anxiety, depression, eating disorders, self-harm, and self-harm, they were all counted in the 2 years prior to a children entering care. The other conditions, schizophrenia, bipolar, and learning difficulties, learning disabilities, ADHD, and autistic spectrum disorders were all counted if there was a diagnosis ever at any point in those adults. So yes, you can see this is very high. So in terms of social services perspective, you know, nearly 50% of the households they are working with have an adult who has been in touch with health services because of depression in those last 2 years. So that we know that there will be all these risk factors will probably be more prevalent than are picked up in the health data. So you know, the true levels will probably be even higher than this. Where the green bars are much bigger than the purple bars, it shows there is a stronger impact of that risk factor on the likelihood of care. So you can see for some things like drug misuse, there's quite a big difference. So it's different to, say, for a depression, where there's only sort of twice as much. Drug misuse is quite a lot more prevalent in the households from which somebody has entered care. Now, what you will probably be aware of already is that quite a lot of these risk factors are all related to each other. And, you know, so where there is drug misuse, there may or may not also be alcohol misuse. Where there's assault at home, may be more common where there's alcohol misuse, and so on. They're all connected to each other. And so what we as researchers do, if you're looking at something like this, you think, well, is it the drug misuse? Is it depression? Are they going into care because of depression? Or is it actually just because these risk factors are more common in households where, you know, depression is more common when something else is going on? So as researchers, we can build sort of statistical models that enable us to look at how much impact each of these things have over and above their combined impact. So that's what I did with this data, and this slide here shows you some of the findings of some analysis I did doing that. So if I explain to you what these means, the risk factors that I have just mentioned are all listed here down the left-hand side of the the chart. And next to each risk factor, at some point, there is a sort of black dot. Now, each of those dots show, it's called an odds ratio, and it shows you how much impact that risk has on the odds of a child going into care. Now, if a risk factor had absolutely no impact on the odds of a child going into care, then that dot would be sitting on this red line. It would be 1. And then the further away from 1 that the dots are, the more of an impact those risks have on the likelihood of a child entering care. The black lines either side they're called confidence intervals. So that's basically how confident we are that the dot is in the right place. So you can see from this that drug misuse and assault at home are the ones that are furthest away from this line. So those are the risk factors that this model is showing are having the biggest impact over and above everything else. Some of the risk factors where the lines, so these confidence lines either side, overlap with the red line going through 1, then we're not actually really confident from this data that there is an impact over and above everything else. So we can see there's quite a lot of difference in different types of mental health disorder, for example. So schizophrenia is having a much bigger impact than bipolar. And we're not that confident that bipolar is definitely having much of an impact once we've taken everything else into account. Most of the risk factors are having an impact over and above everything else, including, as you can see, the learning difficulties. So we can see that these cognitive problems may be having an impact that is, something that social, that might be, we might need to look at how literacy issues might impact on the likelihood of care. Autistic spectrum disorders are not having an impact over and above, once we've compensated for everything else. They don't seem to be, in parents, autistic spectrum disorders don't seem to be related to a likelihood of care, or diagnosed autistic disorders in parents don't seem to be having an impact on the likelihood of care. Right, so the next thing I did then was to look at these risk factors in all sorts of different ways. So I looked at what the different effects of the risk factors were when they occurred in different household members. I also looked at whether the presence of an adult in the household with no risks was a protective factor. It was. I'm not going to show you the way I did this analysis was through a whole load more of these regression models, but I'm not going to show you every single one on this presentation. I will be publishing them all within the coming months. So if you're interested in looking at the details of them all, that there will be more information available. I also looked at the impact of these risk factors in different household members. So, and this was biological mothers, men, and other women in the household. And when we did this, we found that most of the risk factors were having a much bigger impact on the odds of care if they occurred in the biological mothers rather than in other adults in the household, and including any kind of men in the household or other women in the household. So that was it was quite a staggering difference, and we wanted to unpick it a bit because it's quite complicated, because households have different members of the households. We didn't know who the men were. So we decided to look just at the single parent households, and I looked at single parent households that were headed by a woman, whether it was the biological mother or another woman, and single parent households that were headed by men. And I'm going to show you some results of another regression model here, in which I looked at some of the risk factors. I couldn't include all of them in because some of them were not, you can only include it if it's sufficiently prevalent in the population to make this type of analysis work. So these are the risk factors that I included in this particular piece of analysis. Now, there's two different models here on the same chart. The green dots are the odds ratios that I got from a model looking at the impact of these factors in women. And the, I think they're black, but they could be navy blue, dots are the impact of these odds, these risk factors in the model looking at single men households. There were 53,500 households with single women and or nearly, well, not quite 5,000 households with single men in. So as you can see from this, virtually all of these green dots are further to the right than these black dots. So showing that these risk factors, even in the single parent households, are having a much bigger impact if it's a single woman than a single man. Disregarding all of this, there is a slightly higher odds of children going into care from a single man household than in a single woman household. So the thing that it's having an impact on is slightly different, but they are having a much bigger impact in households with single women. And for some of the men, a lot of the risk factors for the households with single men, they're not even you know, a lot of them have confidence intervals that overlap with this red line. So we can't even have enough data to say that they're really having an impact in single men. An exception is this is anxiety. For anxiety, the green dot for anxiety in the single mothers or the single women who are heading households was not significantly related with the likelihood of the children going into care, whereas it is in single men households. So basically, that there's quite a difference in terms of the parent's gender in the impact that these risk factors are having. We didn't know why this is occurring, and we would really like to do some more work trying to find out a little bit about what could be the causes of this quite you know, this such a big difference between the single women and the single men. The next thing I looked at was the interrelationship between risks and deprivation and poverty, and I did this because, as I think I mentioned earlier, we know that there is a relationship between the likelihood of care and children going and people living in it, both areas of deprivation and having poverty in the household. But we wanted to find out how much that was due to a higher prevalence of these risk factors in those areas. We also wanted to find out if there was any evidence that the risks have a different impact either in areas of deprivation or individual level poverty. So do they impact on the likelihood of care in the same way in different areas? And we did this using two measures. We had the Welsh Index of Multiple Deprivation. I'm sure many of you may know about this, but in case you don't, it's a measure that you can use that measures small areas in Wales and divides Wales into small areas and ranks them from the most deprived to the least deprived based on a whole range of different measures. And you can use this to then look at whether those households were in more deprived areas or less deprived areas. I also used whether there was a child who was eligible for free school meals in the household. And I'm sure most of you know that was available to people with certain levels of benefit during the period when this study took place. So this chart shows the relationship between free school meals and deprivation in the households where a child entered care. Now, there have been quite a lot of previous studies that have provided charts a bit like this, where we have shown, or where other researchers actually have shown, that deprivation is related to the likelihood of children going into care. So this first long bar here, number 1, is the 10% most deprived areas in Wales. And this one, number 2, is the 10% next deprived areas in Wales. Number 3, the third least 10% deprived areas. I hope I'm making sense. Going all the way up to number 10, which is the 10% least deprived areas in Wales. So you can see in terms of overall numbers of households that have children enter care, we've followed the same pattern as many other research studies have previously shown. So, but what we've looked at here is also the individual level poverty, well, a measure of individual, quite not poverty, but a measure of individual level low income in terms of the free school meals. So you can see that those with the this kind of pinker plum colour are the ones that are not eligible for free school meals, and those with the darker, I think it's a dark blue, were eligible for free school meals. So this contrast between the most deprived and the least deprived is actually slightly more stark in those that are eligible for free school meals, but it is still there even among those who are not eligible for free school meals. We know there's a lot of people who have living on low incomes who are not eligible for free school meals. So this may be an indication of that, but it does show that this difference in the impact of deprivation is still there over and above these things. Now, I did a whole range of regression models looking at this with my risk factors. I'm not going to show you because I'm just giving you a whistle-stop tour of some of the findings this afternoon. But this additional analysis showed that some of the effects of deprivation and of free school meals on the impact of children going into care was because of the risk factors. But actually, there were some effects over and above the risk factors. There's quite a lot of issues that can be discussed about that. I don't have time to go into it, but that was what the finding was. I also looked at whether there was any evidence of the risk factors having a different impact on the likelihood of care in areas of high deprivation and low deprivation. And I didn't find any evidence of that. So what I mean by that is people in areas of high deprivation are still much more likely to go into care than people in areas of low deprivation. But any of the risk factors, for example, drug misuse, if it had a sort of increased the odds of care by about 3.5 times, it increased it by about 3.5 times in areas of high deprivation and in areas of low deprivation. So the amount it's increasing the odds of care is the same, but it is increasing something that's already much higher. I hope that makes sense. I also looked at whether there was the impact of the risk factors was the same in households where there were free school meals and where there weren't free school meals. And actually, for many of the risk factors, it was the same. The odds of care were the same. But for 3 of the risk factors, deprivation, assault at home, and self-harm, they had more of an impact on the odds of care if the households were not in receipt of free school meals. I don't know why that is, something that might be interesting to look at with some further research. The next thing I looked at was child factors, and I looked at that in to find out how much the characteristics of the child impacted on the effects of the risk factors. And I looked at the child's sex, the child's age, and the child's ethnicity. Now, I've got some very interesting findings relating to ethnicity, but we're still discussing them with user groups and colleagues on the research team. So I am not going to be mentioning them today, but I am going to come back to them. I will be publishing some things to do with them in a few months. So if anybody's specifically interested in that, they're very welcome to email, and we'll make sure that we share those findings with you when we're making them more public. In terms of the child's age group, the risk factors have quite a different impact on the likelihood of care across the child's lifetime. So I split the children into 4 groups: the 3 to 6-year-olds, the 7 to 10-year-olds, 11 to 15-year-olds, and 16, 17-year-olds. They're pretty much based on sort of different stages of the school progression. And you can see that the 3 to 6-year-olds were the most likely to enter care of this group, and then the teenagers, or the 11 to 15-year-olds rather, and the other 2 groups slightly less likely. And I'm just going to show you one more regression model finding, just so you can see the difference of the impacts across the different lives, across the ages of these children. So something here that's maybe quite obvious: the red dots represent the impact of the risk factors on the 3 to 7-year-olds, the green dots on the 7 to 10-year-olds, the blue on the 11 to 15, and the this kind of yellow colour on the 16 and 17-year-olds. So you can see that, for example, drug misuse problems are having a much bigger impact on the likelihood of care on the younger children. That's probably expected, but you can see they're still having an impact in the older children. So that applies also to assault at home. So where the adults in a household have been the victim of an assault that's taken place at home is still significantly related to the likelihood of care, even in these older children, but not by quite as much as it is for the younger children. But then for other risk factors, they become less significant when you're older, or less likely to have an impact. So you can see here schizophrenia is having an impact in these younger children, but not really in the older children. And the same with the learning disability, isn't impacting on the 16 and 17-year-olds really. So that's quite interesting because and maybe not expected. You can see and I suspect, I mean, this is something that would need to be followed up with further work, but there may be different mechanisms through which a drug misuse issue may be impacting on the teenagers rather than on the younger children. But we can't see that from this at this stage. For the teenagers, you will notice that that it is now their issue. So these are still all in adults in the household, but the child's special educational needs, but this is whether they were statemented or eligible for School Action Plus, and if that occurred, then that had the biggest impact on or had a bigger impact on the likelihood of care for these teenagers, the 11 to 15-year-olds. So there's more to do with their issues at that age. And then I don't understand, the free school meal status had a big impact on all the children, but for some reason it was having a biggest impact on the 7 to 10-year-olds. I'm not quite sure why that's occurring. We would have to look at quite a lot more issues to understand that factor. So local authority effects. Now, as you know, or you probably know, the chances of children going into care in different local authorities is quite different. So some local authorities have more children entering care than others. We also know that the nature of those local authorities is different. Some local authorities have higher levels of these risk factors than others. Some local authorities have more areas of deprivation than others. So when you're looking at how local authorities differ in the likelihood of children going into care, then it's really a complex picture, because you need to factor in how much impact these issues are having. So that's what I did, some more work to look at this. So are the effects of the risks the same in different local authorities, and how much of the existing differences between local authorities is due to different levels of the risk factors? And when I did this, I did it by more regression models, which you don't need to understand, but I'm going to show you some more charts here and explain what they mean. So this is a different kind of regression model where I had looked at the impact of how much these 22 local authorities in Wales differ from what you would call the average local authority. So the red line here is the average local authority. If you are a quant person and you're listening to this, these are group level residuals from multi-level models. If you're not a quant person and you're not wanting to work out what they are, all you need to know is that they are the 22 dots represent the 22 local authorities. In this particular model, I haven't added any of the risk factors yet, or deprivation or anything. All I've looked at is how different each of the local authorities are from the average in how likely children were to enter care. And we're talking very specifically about 3 to 17-year-olds between 2016 and 2020. So we don't know that it's exactly the same now, but this is an example of what you can do with this kind of analysis. So if you can see here, the typically average local authority would be sitting here on the red line. The further away from the red line, if you are above the red line, that means you're more likely to have children entering care. And So you can see this local authority here on the right is the, in fact, all the higher, they're all on the right, is the one that is most likely to have the most children entering care. And on the far left, these are the ones that are likely to have the least children entering care. They've all got their own little confidence intervals. They're all a dot, but they've all got these things. So the ones that cross over the red line are more or less the same average with each other. So there's not much difference, but you can see this one here is clearly quite different to the rest. This one is also fairly different. And we've got some here that are definitely well below average in the likelihood that children enter in care. So this is without any risk factors, but then I did another model, included all the risk factors and the level of deprivation, and to look at then how much all these local authorities vary on the likelihood of children entering care. And you can see that when I did this, I got this pattern. So these are, again, this is 0. These are the ones that are behaving in quite an average way. But we've now got 4 that were actually, when you factor in the amount of deprivation and the amount of risk factors in those local authorities, we've got 4 that seem to be far more likely than average to have children entering care. And we've got sort of 5 down here that seem to be less likely than average. They're not clustered in such an obvious group as the other ones, but they all seem to be less likely to have children entering care. Now, what happened when I put all those risk factors and levels of deprivation into this statistical model is those that had higher levels of deprivation and more risk factors in their population, they moved to the left. And those that had less deprivation and less risk factors, they moved to the right. So I've just got another version of this chart so that you can see where they originally were. So these numbers on here show it's the same findings from the same analysis as the chart I just showed you, but these findings show you where they were before. So you can see number 22 was the rank here. So this one was number 22. I labeled them 1 over here, all the way up to 22 here. So when we accounted for the levels of risk and deprivation, number 22 moved from the most likely to have children entering care to actually, well, still the third in this group here. So still very likely to have children entering care. But in terms of the practice and how much the local authority is likely to put into a child into care, they're no longer alone, they're with another group. These two, 15 and 16, were somewhere around here in the original model and didn't look like they were putting that many children into care, maybe a bit more than average, but not much. But when you factor in the nature of those local authorities, actually they're putting in quite a lot more children. And then likewise, we've got some that have moved the other way. And this one here, number 18, is quite interesting because that was, you know, somewhere around here at the beginning, and it's moved all the way down here. And that is a local authority where there are high levels of deprivation. So I think this is just a really useful method for comparing local authorities. And it does mean that we can start pulling apart what is to do with practice and what is to do with the factors, the populations that those different local authorities are working with.
Nell, just to say you've got 5 minutes left.
Brilliant, thank you very much. So the last piece of analysis that I have been looking at is how these factors have changed over time. And actually, I'm not going to present too much of this today because, again, it's the final piece of analysis and we're still looking at working on it. But I have done this to look at, one, if the effects of the risk factors are the same during different periods, during different time periods. So I repeated the analysis with data from, so this initial analysis was carried out with data from 2016 to 2020. I repeated it with 2 earlier cohorts. So I looked at data from 2008 to 2012 and 2012 to 2016. And I repeated the analysis. Some of it had to be done slightly different because some of the data wasn't available. For example, the substance misuse data set didn't go back that far. But I've done this piece of analysis to look at whether the effects of the risk factors are the same during different time periods. So do they have the same impact on the odds of care now as they were having, 10, 12 years ago? And can we see if this accounts in any way for the increases in the numbers of children that have been entering care during this time period? So, like I say, I'm not going to present all of this now. The preliminary results do show, though, that most of the risk factors, the vast majority of them, actually are having the same effect on the odds of care in all three cohorts, or more or less the same effect on the odds of care within all three cohorts. There is a difference in depression in households. That seems to be, that is having the same impact between 2012 and 16 and 2016 and 2020, but there was an increase in the impact that depression had in households over and above all the other risk factors between 2008 and 2012. But most of the other factors don't seem to be having a big impact on a different impact on the odds of care, although there are increases in some risk factors in the population, particularly depression and anxiety have increased over the time period. So it may be increases in problems rather than a difference in practice that is accounting for those, for some of the numbers. But we're still sort of going through this data at the moment, and we haven't published it yet. So we're giving you a brief indication of what's to come, but haven't got the details of it yet to publish. Okay, so thank you very much for listening, and I'm very happy to answer any questions that you have about any of this.
Yeah, thanks so much, Nell. That was so insightful, breaking down the factors impacting children entering care for different groups across local authorities and over time. I definitely found that very insightful. If anyone has any questions, if you could either raise your hand or write them in the chat, and I'll read them out. So I'm just looking at the chat now. We've got one from Sian Thomas. She says, is it possible to have that information with local authorities listed rather than numbered?
Listed in terms of which local authority is which?
I'm assuming so, yeah. Yeah.
I think it is, because that's how I exported it from Sale. What you do find with Sale is, and quite rightly, they are very conscious of what sorts of data you're allowed to export. But I did export those rankings with the names of the local authorities on. I haven't put them on the charts, but I can do it when it's finally published. So yeah, we can do that. But it has to be remembered it's with a proviso that it is for a very specific time period, so, and for the certain age group of children, so we don't know that it's now exactly the same. But yeah, we probably will put that in the final publications.
Great, thank you. Helen Hodges says, I am assuming that you have determined the parental factors based on the linked data. However, I was wondering if your work gives a sense of the quality of the parental factors recorded in the children receiving care and support census. Was this something you looked at all?
Okay, thank you, Helen. So as Helen rightly says, there's different sources of data available in the Sale data bank that we could use to find out about things like risk factors. One of which is the children receiving care and support census, which is data collected by local authorities about children receiving care and support. I didn't use it for the analysis because well, two reasons actually. One was because I wanted to look at the comparison population. So the comparison population are not in the children receiving care and support census. So we needed a measure that was available for everybody in the entire population, rather than just people who are known to social services. The other thing that I think is useful about using health data for these findings is that the health data we don't know if all social services, the 22 local authorities, all record exactly the same levels of risks in the children receiving care and support, or we don't know that they all know about the same things, or we don't know that social services will definitely know about things. So using what is in health provides in some ways a much more objective difference. But I think it would be really interesting at some point for somebody to compare what is in health with what is in the care and children receiving care and support census, to see how similar they are across different local authorities. Thank you.
Yeah, I completely agree, Nell. I think that that's a piece of work that needs to be done. So Caroline has asked, is this or has this information presented to local authorities so that they consider the findings?
Some of it, when I should have probably mentioned, some of the differences in local authorities, we have actually followed up with some qualitative work, so some focus groups in some local authorities. So it has been presented to them. And then I have now got some work coming up with local authorities. I'm doing a presentation at the ADSS conference next month in North Wales, and I'm also going to do some work with Social Care Wales, presenting findings to local authorities. So it's a kind of ongoing process, and I'm happy to present it anywhere else if people know of additional sources that would be interested in hearing about this.
That's brilliant. So I don't think there's any more questions, and there aren't any more hands up. But I do have a question. Which parts of this research do you think has important implications for practice?
Okay, thank you, Sophie. So there's quite a few bits where I think there's implications, and also some bits that will have implications, but perhaps need some more work, in some cases qualitative work. I think the finding in terms of the parents with learning difficulties, so not disabilities, not the cognitive problems, but even learning disabilities as well, but the literacy issues and things like that might be really useful for practice, because it might be that some things could be presented in different ways, or things could be done relatively straightforward to make it easier for information to be accessible to some families. The other things I think that would be useful would be well, I think for some of the differences in local authority effects, I think that's quite important for trying to work out which local authorities have got higher rates than might be expected, or lower rates than might be expected, and trying to unpick why that is. And then I think that a lot of the other findings to do with some risks having certainly the gender of the parent, or the sex of the parent, is quite an interesting one, because it does appear that risks are having a much bigger impact if they occur in mothers than in fathers. And there's another body of work, of research that's been carried out, which has been sort of pointing out that maybe social services interact differently with fathers than with mothers. So there may be some really important implications there, that we maybe need to do some more research looking at why that is happening, maybe qualitative research, but there may be some implications coming out of that.
Yeah, definitely. And what plans do you have to take this work forward?
Right, thank you. So at the moment we're doing a lot of dissemination work and finishing it and writing it up, and I am will be very happy to share the findings with anybody. I think it will come out, we can publicize the publications through ExChange, but also if anybody wants to email me, I've got my email on the next slide here. So this is my email, Nell Warner, warnerah@cardiff.ac.uk, with any questions about this, or because they want to follow up with some more information about it. So that's the first thing. But the other thing that I'm going to be doing is, I know that this is only kind of part of the issue, because the numbers of children in care are very high in Wales, and that's partly because of the children entering care, but it's also depending on how long the children stay in care once they're in care, and whether they go back home. So I have just received some more funding to do some work with local authorities, looking at children returning home from care. So that's going to be done in a whole range of different ways, and some of that will be qualitative work, actually talking to families and social workers about it. But and there will be a survey with local authorities about factors relating to children returning home from care. But there will also be some data, some work with data in SAIL. So, and some of that will again look at some of these risk factors in households. So we'll find out, you know, not just what impacts children going into care, but also what impacts children returning home from care, and which of these families children are most likely to return to and stay at home if they do return.
Wow, that sounds really interesting, and a great next step for this piece of work. And we'll all be watching this space, I think. So thank you so much, Nell, and for the ExChange team for organising this webinar, and for everyone else for taking the time to come and listen to it. Yeah, thanks so much.
Okay, and yeah, thank you from me as well, for everybody for coming.